the shoulder in all planes. You can have a patient do some passive range of motion. I mean, there are a lot of different ways to do it. But you want to make sure that the patient is definitely safe enough to do it before you have them work on it. I can think of... hang on. So sometimes we'll do passive range of motion with people post-surgically. I mean, obviously, with passive range of motion, you can do it to create some body awareness with somebody. You can also do it to try to stretch or gain motion to minimize any compensation that the patient may be creating as a barrier to progressing. But post-surgically, we'll do passive range of motion in the clinic, and then one of the more common ones that I use is I have people do passive range of motion on a tabletop or a countertop with a pillowcase. So I'll have them put their surgical arm, their hand flat on the table or countertop, and I'll have them put their other hand on top, and they can work on just kind of bending through the trunk and the hips. Try to do some nice gentle flexion, passive range of motion. Okay, so I'm actually moving through the hips and pelvis, and my shoulder is kind of just going into flexion along for the ride. I can also have the patient rotate their feet, trunk, and I can have them work passive range in scaption. Okay, so a little bit more at an angle. Or I can have them work a little bit in abduction. Okay? And this is in a position where gravity is not having a significant effect. I can show you a couple techniques in the door jam to do this also. But I find that this is the best way for the patient to actually relax their affected arm and, again, to use motion from their pelvis and trunk to try to generate some of that passive range to the shoulder. You can also do it for someone who's maybe not post-surgical. You can do the same thing. If they have the stability, you can do the same kind of thing with the ball. So, again, if someone has had surgery, I'm less likely to do this because I wouldn't want them to accidentally slip and put strain on their repair. But if someone did have pain and they wanted to work on stretching some tissue out, they've been in a sling for a long time and they were stiff, this is a little bit more dynamic. This might be a little bit more active assisted, but certainly you're getting some passive stretch too. So same thing, okay? And the thing that's nice about the ball is it allows a little bit more free movement than just sliding on a surface. Okay, same thing, flexion, scaption, and I can do a little bit of abduction. And I can think of a few times where I've had maybe a patient come across a little bit and do some stretching into horizontal AD for more functional tasks, maybe. So it kind of just depends on what the patient needs. But I found that the patient is much better and able to relax if you have them doing some movement with the arm in a relaxed position and using the other arm to kind of help reinforce it and keep it in a safer position. And then there's another way that we use, that we do some passive range, and that is the use of a pulley system. And so basically, it's a pretty simple apparatus in which we would have a couple of handles, and then there's a little pulley thing that usually goes over the back of a door frame, and then the patient can... Yeah, go ahead. Just kind of run your fingers around it in a circle. So the patient would have to, this is harder because the patient has to physically try to let their shoulder joint go. And then basically they would do this kind of a thing where they would drive the motion upward using their unaffected arm and let their affected arm kind of go up. And you can work flexion, and then you can rotate your body, you can do scaption, and then you can rotate further, and you can do abduction. Okay? So pulley systems are available. They're nice because they're generally pretty affordable. I think my vendor sells them to me for $6.
Wow.
So they're a pretty easy sell. The patient can do them quite frequently, and they're pretty easy. You can set. The patient can take them with them to work, because all you do is just hook it right over the door frame. And the only major thing that we should talk about, if we're being honest, is that a lot of the new evidence shows that there's not a lot of carryover to functional range of motion after the use of pulleys. So, yeah, they're cheap, they're readily available, they're easy to use, but the research isn't supportive of it. So, there are therapists out there. I happen to work with a couple who don't do pulleys because there's no evidence for it. And then there are other patients who significantly benefit from it. So, it's one of those gray areas that we face. Any other passive range techniques?
Those are good ones.
So we talk about pendulums, or is that more ortho?
We'll leave that for work though.
Okay. So, active assisted. This is going to be one of your staples of shoulder rehabilitation, and you may go over this more in ortho, but these are called wand exercises. They may be called cane exercises or broomstick exercises, depending on what's available to you in the clinic and or to the patient at home. I personally don't have a cane at home, thankfully, so I would probably be using a mop or a broomstick for this. And basically, it's a way to do active assisted range of motion. Okay? So, I typically am going to have my patient start in supine, okay, so in a more of a gravity eliminated type position, okay? And going into flexion, again, your unaffected arm is in theory trying to go along for the ride while your affected arm goes along for the ride while your unaffected arm kind of drives the cane up and overhead. And there are different ways to do this. You can grasp with both forearms in pronation, so the shoulders are both internally rotated, and you can kind of come upward to gain motion. Okay? Or I have seen it where the unaffected arm comes underneath with the forearm supinated to try to help kind of carry the weight of the affected arm up and overhead. So it's kind of creating a little bit more upward momentum. I've seen it both ways. But typically, you're going to have both forearms in pronation. Okay? So this is to gain flexion. Okay? Then the other thing that we do a lot in supine is we work on external rotation. And again, you want to be very intentional in where and how you instruct the patient to be as far as abduction angle. So you may have them just start with their body completely in adduction. Okay? And you're going to have them hold on to one end. In this case, I have a handle, which is convenient. And you want to be careful when you go into external rotation that the patient's not extending through their elbow. Okay? Because that's not what we're trying to gain. We're trying to gain external rotation. So I typically try to tell them to keep the arm that drives the force into rotation, the unaffected arm, down kind of closer towards their pocket to work a little bit at an angle. Because again, their tendency is going to be path of least resistance, which is elbow extension. So here with my arm in abduction to the shoulder, I'm going to do a little bit of active assisted into external rotation. You may also do some into internal rotation, but typically these patients are going to be, after an injury, are going to be put in a sling, or this is going to be their position of comfort and protection. So they're going to be in plenty of internal rotation anyways. So you can work into internal, but most commonly you're going to work on gaining external. What else am I forgetting besides AB, internal, external? And then again, the progression for flexion would be to start doing it standing. Okay? So this is a little bit more of an intermediate wand cane exercise. Typically, I don't do AB in supine. I usually do it in standing. And again, I may work on scaption here. But I can also do abduction in a limited range here. Okay? You can also do some external rotation here. more functional. Okay. And then extension, you do it with the arms behind. So with this one, I basically just have it looped around, my elbows are extended, and I'm just going to work on kind of driving into some functional extension. Okay. So depending on the patient's needs and deficits, any precautions, you want to be mindful. You don't necessarily work every single one of those planes, but these are wonderful, and like I said, most people have a broom or a mop at home that they can do this with, and it's a nice way to use the unaffected arm to facilitate some range of motion needs. And you guys may talk about that a little bit in ortho. It's a pretty common practice after orthopedic surgeries, dislocations and things like that. Another one that's utilized, if you don't have any equipment available to you, are kind of finger crawls, wall walks. I've heard them called spider crawls. Basically, you're going to have the patient, if you're working on flexion, you're going to have them face the wall. You're going to have them put their affected hand on the door, and you're either going to have them walk their fingers up, and you can see that my shoulder is beginning to go into some flexion as I move my hand up the wall. You can also kind of crawl through your hand and palm to gain motion. Okay? And so typically, we're going to have the patient go up, okay? And then you can have them kind of do the reverse to kind of slowly lower. After you have them go to the point where they feel some tension, some stretch, some pain, you may have them put their hand flat and just hold it there. Stretch for a second before they come back down. So we want to go to that point where you feel some tension, stretch it out a bit, and then come back down. Okay? I can also have the patient rotate their feet about 45 degrees, maybe a little more, to work on scaption, a more functional range. And then I can have them rotate all the way. This is going to be the most difficult for the patients typically. And I can have them work in a frontal plane to work on gaining abduction. Some clinics are fortunate enough, I think they have one next door, to have an actual fingered ladder. You may see those in the clinic. They basically have slots about every inch where you can actually physically stick your finger in a groove, and it's a ladder built just for that active assisted range of motion purpose for the shoulder. So for those of us who don't have any fancy equipment and preparing someone to do this at home, you may just have them do the finger crawls, the hand walks. Some people call it the itsy bitsy spider, whatever works. But like I said, you can have them work on crawling in the different angle that you desire, and you can have them kind of stay in the position where they feel that minor pain, pull, stretch, whatever it might be. We utilize the door jamb a lot to gain motion. Because again, it's readily available, we have easy access to it. So if someone has a deficit going into external rotation, I'm going to have them put their hand on the door frame, and I'm going to have them start by facing the door frame. And I'm going to have them turn their feet slowly out and away to work on gaining some of that external rotation motion. Okay? They can hold it for a few seconds, stretch it out a bit, and then they can turn their feet back. So my arm isn't really moving, my elbow is staying relatively close to my side, I'm just turning my body away. So all I'm doing is walking my feet away. Okay? And then, I don't know that I necessarily do that for internal rotation all that much, but if someone has a deficit, you could work on it a little bit. I just don't think that's quite as common. Like I said, because most people, when they come in for therapy, they're in the safe, protected position where their shoulder's already in quite a bit of internal rotation. Hook the door jamb, walk the feet away, get some range of motion. Low load, long duration, internal, external, with weight, I assume? Right here for you. Supine? Okay. So we would put the patient in a similar position to how we assess their range of motion. And in order to facilitate gains, we can have them add some lightweight into their hand, try to work on gaining motion. It's very important, as with range of motion assessment, to minimize any compensation that might be happening, because we want to promote the gains through the glenohumeral joint, not through the thoracic spine, or through translation of the humeral head, or whatever it might be, right? So instead of just coming back like this, I would probably start with a little bit lighter weight than this, to be honest, but just for the purposes of demonstration, we would have them hold the weight, and the weight with the effect of gravity and the limb would kind of help gradually bring the arm, or bring the shoulder back into some external rotation. So I mean, it doesn't have to be 2 pounds. It can be. I've had patients hold.
Hold the remote control.
Yeah, something really light. I was gonna say I've had them hold small tools or a rolling pin. Usually it's less than a pound, because the effect of gravity alone helps quite a bit. If you give them something light to hold. So you can do this to gain external or internal, but again, I like to have the patient put their hand on their femoral head just to make sure that they only go to the point where they feel that start to kind of come forward, and that's where they kind of stretch. And they can apply a little bit of light force just to maintain that humeral head in position. But that's kind of a low load, long duration stretch. So the patient has to be able to tolerate it. The patient has to demonstrate that they have the body awareness to hold the stretch in the right position and to avoid compensation. And they need to be carefully instructed not to overdo it. Because if they do a low load, long duration stretch for too long, they can have a fair amount of soreness.
Yeah, PNF stretch your internal and external rotators.
Sure! Let's do it on my non-damaged side.
The same position that Brian was in before, we've talked about PNF stretching using contract, relax, or hold, relax. So I can have him in this same position here. Say he's a little tight in external rotation, that's as far as he can go. I can have him stop right there, give him a little stretch and say, all right, pull into my hand, hold it, hold it, hold it, hold it, and relax. And as he relaxes, then I can take him into more range of motion. But I'm stabilizing his arm, give him a little rest right there, pull into my hand, hold it, hold it, hold it, and relax. So I can do several repetitions to get him into more external rotation. Same thing with internal rotation. I'm just watching the form again, watching the shoulder, trying to keep him in this nice position. We can do it in different degrees of abduction as well, but I can do the same thing, just have him go into internal rotation as far as he can go. Okay, press back into my hand, hold it, hold it, hold it, and relax. And then I do keep my hand typically here so I can give him a good stretch like this. So PNF works really well with internal and external rotators here.
Facilitate AC and SC joint movement, so shoulder rolls. So basically what we can do to get some mobility through those stiff joints after someone's been in a sling or a brace, or they've had orthopedic precautions, you can just have them do some general rolls in both directions. And again, we're getting a little bit of movement down here in the sternoclavicular, and we're also trying to mobilize some of those ligaments that might have gotten tight in the AC joint. Okay?
I don't think you did the internal rotation stretch.
What did I forget?
Lying or standing.
Oh yeah. With a weight?
Or just, I usually use my own hands.
Oh, got it. Sideline?
Yeah.
Sorry, I skipped one.
No worries.
So, what you can do, if my affected side is my right side, let's say, what I like to do is kind of roll towards the, so I have them in supine in the test position, then I'll have them roll onto their side, and then you can have them come down, and then you can apply a little bit of overpressure to try to stretch into more internal rotation. And can anyone tell me what the benefit of this might be?
Shoulder stabilized.
Yeah, you're getting a little bit more stability. I feel like my scapula is blocked more than anything. My scapula just doesn't want to move. So this is a little more pure glenohumeral joint movement. So I can use my contralateral hand to apply some extra overpressure. I've had patients do the low load, long duration stretch here with this, in this position.
So if your patient wasn't able to get in sideline, you could do the same thing up against the wall and just be side standing up against the wall and do the same thing. You're blocking the scapula against the wall and giving some pressure.
Nice. Feels really good. Just want to make sure you educate them not to overdo it. They will. They'll put a lot of force to it. I don't think there's anything else. Yeah, I mean, and a lot of the stuff we talked about last week for the scapula, you know, some of it can, more indirectly help us gain shoulder range of motion too. So there's definitely some carryover there. And with some of them, you can get 2 birds with 1 stone, which is nice. But I would say out of all of them, you're going to see a lot of wall walking. You're going to see a lot of wand exercises. And you will likely see people out there using the pulleys. Like I said, it's a cheap piece of equipment. There's not a lot of out-of-pocket expense for patients. It's generally pretty nice because we need to get a lot of gains to elevation because that's what we do functionally. We do stuff with our arm around shoulder level a lot. So you'll see those out in the clinic. Again, they may be going away as you guys enter the workforce because there's not a lot of evidence for it anymore, but certainly you'll see them being used. I mean, I see them, I go to clinics and gyms and I see fully set up pretty much everywhere. So whether or not they're utilized, I don't know. But they'll definitely be using your wand exercises, trust me on that.